Jessica, as I already mentioned, I'll talk my presentation basically have three components. So starting with a big question of quality, and it's not as simple as it looks. Quality basically is defined as conformance to requirements.
सर
It
स्लाइड
is
शो पे कर दें, सर स्लाइड शो पे कर दें, सलमान साहब स्लाइड शो पे कर दें.
right. Okay. So अभी आपको सही दिख रहा है सबको?
Yes, sir.
Right.
So,
So
we can see it clearly.
Right. So quality is basically defined as conformance to requirements. As I mentioned, it's not that simple, and it doesn't mean that everything that goodness or elegance is quality. Basically, it is set of processes that conform to certain requirements. And let me just highlight an important thing, that even if we have achieved a 99% level of quality, that essentially means that we are accepting 1% error rate. And 1%, that 1% error rate, for instance, in France, every day means that there'll be 14 minutes without electricity and water. There will be 50,000 parcels that are lost by postal services. There are 22 newborns falling from midwife's hand, 3 bad landings, and a lot of contaminations of bacteria. Just this is a study which was shared by WHO, that if we accept that 1% error is quite I would say it affects the processes and the systems. When we come to the laboratory quality, it is basically in order to understand laboratory quality, I think there are three essential things that are to be remembered. One is accuracy, reliability, and timeliness. All the laboratory results that are generated by particular labs, they are accurate. The laboratory operations that are being carried out by the lab are reliable. And of course, important part is the turnaround time, that is how timely the laboratory is reporting back to the clinicians, to the public health authorities, for the purpose of interpretation, treatment, and interventions. And if we look at, I think there are three major impacts of laboratory errors. The first and the foremost is the worst patient outcomes in terms of morbidity and mortality. Then, in case of laboratory errors, extra personnel effort is required, and of course, the turnaround time for reporting also increases. So, in order to achieve excellent performance in the laboratories, the WHO has developed a laboratory quality management toolkit that was developed in way back in 2010, and the focus of this toolkit was to identify a set of coordinated activities or areas that function as building blocks for quality management systems. And this emphasizes a systems approach towards quality management within the laboratory. And there are 12 quality essentials, starting from organization, personnel, equipment, purchasing and inventory, process control, laboratory information management system, documentation and records, occurrence management, assessments, and process improvement, customer service, facilities, and safety. Everything is linked. Everything is important, and these 12 pillars, 12 essentials, I think they are to be understood by all the laboratory personnel, whether they are working in microbiology discipline, pathology, or any other discipline, pathology, hematology, histopathology. I think these are the cross-cutting themes, cross-cutting areas, and we have to emphasize and look into and educate our laboratory workers in these areas. By definition, as I mentioned earlier, quality management system covers all aspects of laboratory operations that need to be addressed to assure quality, and that actually is basically a quality management system. Um, if we look at as a laboratorian with more than 20 years experience, we and many other laboratory colleagues which have joined today, they will agree that laboratory operations are not that simple as it looks. I think it's a complex set of operations that are going on within the laboratory. Uh, the pre-examination, then there are examination or analysis part, and then post examination part. In pre-examination, I think there are several areas that needs to be seen: personnel competencies and evaluations, patient client preparation, sample collection, and lot of information. Lot of effort is required in all these pre-examination areas, because they actually affect the quality of results. Sample transportation is very important area. There are and we have actually faced a lot of challenges during the COVID epidemic, COVID pandemic, in all these areas. And whatever I have mentioned, I think that truly reflects they are all the, the pillars, all the systems have been challenged by COVID pandemics. And I will as I move forward, you will realize how we manage things. Sample receipt and accessioning, very important part, and its labeling and documentation. I think these are very critical, and they are important to be addressed. Then is the examination part, and we'll talk about that in detail. Quality control testing, and then post examination record keeping, very important. Then information systems and reporting. I think these are the challenge, and everything which have been mentioned here, I think that has been tested with our experience of high throughput testing for COVID-19. So coming to quality control, I think just to give an overview of few important areas that are required for maintaining the quality for COVID-19 or SARS-CoV-2 PCR. We would definitely have to maintain the integrity of any sample that is coming for SARS-CoV-2, and by that we essentially mean that samples that are collected, they are appropriate samples. The timing of sample collection is very important. We make sure that sample transportation and processing and they're very important. We have to look within the laboratory. I think it's important to see how to control the contamination, and while performing the test, the use of positive and negative controls. And lastly, I think a very important part is external quality assurance, and by that we essentially mean proficiency testing for COVID-19 PCR. So before just going into some details of these analytical factors, I think it's important to mention here that once we started COVID-19 testing at NIH, it was on 1st February, and we received first batch of around 10,000 PCR tests from China. They were flown back to a special plane from, and NIH teams went there, and we brought in those kits, and we started optimize the assay here at NIH. And our first case was detected on February 26, 2020. And once we started testing, I think a very important issue was to roll out this testing, to roll out this COVID-19 PCR-based testing across Pakistan. I think that was the early days of pandemic, and we immediately developed a package, a very concise package of training for the staff of the private sector lab provincial laboratories. We have a network of provincial public health labs. There are 4 provincial public health labs, one in each province, and our target was to train the laboratory scientists within those labs. And at the same time, we also provided support to the public sector lab for establishing COVID-19 PCR. And till that time, NIH has to take lead. We have to take care of all the samples, especially from the upper part of the country, to test all those samples for PCR, as we were able to optimize that. So coming back to the pre-analytical factor, I think all the 3 pre-analytical, analytical, or post-analytical factors are very critical for any laboratory test, and likewise for COVID PCR, and especially in a molecular biology setup. Whenever we are doing molecular diagnostics, we have to emphasize on strictly segregated areas. And then the most important part is the biosafety level. And initially, it was thought that COVID-19 or SARS-CoV-2 has to be dealt in a BSL-3, but later on, the global authorities such as WHO and CDC agreed, and European CDC, they agreed that it's a level 2 operation. So biosafety cabinets level 2 were recommended to be used for sample processing. Essentially, the design of the lab must be compliant to at least the 3 rooms. 3 segregated rooms, and we have to look at not only the facility design for regarding segregated areas, but also look at the sample quality checks. We are still receiving samples from district authorities that at times are leaky samples, and they contaminate the surfaces and the personal protective equipments of the users and the laboratory operators, which actually are one of the major cause of cross contamination. Ideally, such samples or such lot is to be discarded. We have to design because of the increasing demand, increasing the number of laboratories. We have to establish a laboratory workflow. And laboratory workflow doesn't mean that we have to look at the flow of the sample. I think very important part is to look at the flow of personnel who are engaged within the laboratory, and flow of the waste as well. And then along with the waste, I think very important to see the flow of the reagents in a molecular diagnostic laboratory. We have to look at prior to running any assay, we have to look at the working condition, the calibration of all the equipment, biosafety cabinets, the PCR machines, the extraction machines, and we have to maintain a run error record, and all such availability of the appropriate capacities vis-a-vis the demand, and the functional power backups. I think these are some of the pre-analytical factors which I have highlighted here. Very important part of pre-analytical factors is the sample management, and we have seen, and in Pakistan, what we have observed is a lot of oral swabs, or I would say throat swabs, were taken. Oropharyngeal swabs were taken. And vis-a-vis most of other countries, they have actually and recommended nasopharyngeal swab. Despite that, the yield was not that bad. But again, I think both the options and both the swabs have their importance, but preference shall be given to nasopharyngeal swab, although it's not easy to collect. It is at times irritable to the patient, and there is definitely more training required for taking a nasopharyngeal swab than taking an oropharyngeal swab. A timing of collection is very important. I think the chances of recovery of RNA from in the early days or prior to any appearance of symptoms, and during the acute phase of the disease, I think there are chances of detecting uh, SARS-CoV-2 RNA are higher as compared to the later course of disease. Use of VTM is very critical, and the proper labeling and tight packing. As I mentioned, there have been examples, there have been instances we have faced that the containers have been leaking and we have to destroy all those batches. In case of triple packing, in case of long distance shipment of samples, triple packaging is required. There have been trainings conducted prior to the epidemic on triple packaging to many laboratories, but I think a large scale rollout of the concept of standardized shipment has to be rolled out in the long term. We do understand that these RNA viruses, they are more susceptible to degradation, and proper temperature condition during storage and transportation are essential to minimize the risk of RNA degradation. And definitely there is need to train the staff within the collection center, within this sample receiving areas, and those archiving these samples and processing these samples. I think there is a need to instruct those staff in use of personal protective equipment, sample handling, and how much and the storage temperature, storage requirements, and how much time is required to keep those samples. I think there is a long list of analytical factors. I think we starting from staff competency, I think very important to roll out a large scale testing at country level. I think there are a lot of need for a competent staff with adequate training to conduct PCR based testing. But it was managed, it has been managed because we have a small, as I mentioned, we developed earlier in the course of pandemic a package of training for public and private sector laboratories, and that actually worked well. Then there is a need for sustainable supplies of reagents, and then the working of the reagents, some storage of reagents from away from the samples, automation, partial automation, and manual testing. So manual testing is quite labor intensive, and has been we have seen that it was not being most of the laboratories, they are not using manual extractions. So, most of the laboratories within the country, they're using semi-automation, that is using extraction machines, and then using those extraction machines, they're able to extract the RNA and then processing them in a thermal cycle. During the processes, there are recommendations to use aerosol barrier tips. There were issues with the availability of such tips, and this problem is still going on, especially during the early phase of pandemic. I think due to lockdowns, limited travel, limited transportation, I think most of the lab faced these issues. There is need for separate pipettes, racks, and PPE and waste containers within the three segregated areas. There is a strong need for adherence to SOPs, documentation of policies, plans, procedures, instructions and records, quality control procedures, and they all impact the quality of the. And I will talk about the assessment within the lab as well, and that includes a lot of negatives and positive controls, and then internal quality controls with certain batches. In fact, with every batch, and these are very important. And just a comment on post-analytical, I think we have to be very careful when producing a final value report, and obviously, and all these processing are going on in a very quick manner, because the nature of the disease and because the concern of the public, because the pressure of the public, everybody wants their results to be dished out as quickly as possible. Uh, and, uh, and managing a large volume is a real was a real challenge for us. And that pressures obviously affect the interpretation and in fact interpretation of the laboratory data, which requires that the operators and interpreters are able to um, review the results generated by the instrument. They have understanding of the CT values and how to adjust them, and they are able to review the raw data before they finalize the results. It is very important that an experienced molecular biologist they look at the real-time PCR results and then transcribe those results to omit any errors. I've just highlighted few of the causes of false positives and false negative results, but important thing is that there has been since most of the people who undergo testing for COVID PCR, they had some people have nag of testing from another lab if they are detected positive or just to confirm and deconfirm. I think very important to realize that if there are two labs, one is declaring one sample as positive and the same patient is declared negative, I think it was recommended globally that the positive report shall prevail in the best interest of as part of public health interventions, just to keep people isolated and quarantined in case there are two reports, one is positive and one is negative. And as far as false and the second important thing that we have to see is that the overall sensitivity of PCR, despite being the gold standard, still remains about 80 to 85%, and there are certain instances where we miss the PCR COVID-19 by PCR. So some of the causes of false negative results includes poor sample quality, its handling, transportation, and or storage. And the suggested measures are to look at the qualitative detection of human housekeeping genes such as RNase-P. In case there is poor or failed sample extraction, I think the very important suggested measure is to use of extraction controls. And time of sample collection, very early or very late during infection. I think the sample, all those who are prescribing the testing and all those who are collecting the samples must be aware of the timing of sample collection to optimize the yield of SARS-CoV. There are certain reasons where we can get false positive. Sample contamination is the major reason, and the contamination basically two sources. One is cross contamination and other is the contamination from previous runs from the qPCR. For both, there is very important that we have SOPs for decontamination procedures and which are being implemented by the respective laboratories. And there is a need for clear SOPs and especially the use of personal protective equipment. And then these using all the consumables within those respective areas with limited movement, limited in fact restricted movement between the segregated areas. We have seen there are kits which have low specificity, and the reason obviously the within issues with the kit targets or storage conditions, especially during transportation, or there are certain other factors. If I remember, we received a large batch from Sindh from one of the kits donated by China, and they were returned back. They were issued to Sindh Health Department, and in fact, they were returned back to NIH. And we optimized those kits, and we were able to use those kits after optimization. But there were certain issues with those kits. I've already mentioned about cross-contamination of samples. I think one of the important measure, again, is to use those dedicated areas or segregated areas to prepare PCR master mix and add positive and negative controls. As I mentioned, more than around 300 or 320 plus laboratories are operational in Pakistan, and the role of NIH was to guide laboratories in designing those laboratories, or how to customize the existing setups to undertake COVID-19 PCR. So it was a very important part, and that actually the purpose of the designing and laboratory construction is to look at the to avoid the contamination.
Hello.
Then is unidirectional workflow. It has to be from pre-PCR to post-PCR. Pipetting techniques are very important, and changing PPE is very important, aseptic cleaning techniques, and inclusion of controls. All these factors helps in prevention of any contamination. I would just quickly go through the last part of my presentation, basically, and before summing up, is the external quality assurance program. I think this is one of the area where we have to be, we were asked by the NCOC at that time to establish external quality assurance program, just to look at the quality of testing being carried out across the country. We initially started our first run in 2020, and in August, September 2020, and up till December 2020, we have completed 4 cycles, and I'll share the details. But the purpose of our program basically is to look at the performance of laboratories. As we know, the external quality assessment is basically the comparison among different testing sites. It provides opportunity to identify systematic problems early, and provide objective evidence of testing quality, and identify those areas that need improvement, and training needs subsequent to feedback. EQA has basically it has laboratory oriented objectives as well as public health oriented objectives. In as far as laboratory oriented objectives are concerned, it enhances the laboratory credibility, and it generates confidence in laboratory results. And public health oriented objectives include reduction in morbidity, mortality, and it obviously reduce economic losses. And the external quality assurance is very critical for improvement and measure of laboratory performance. So this was our I would say very important component of our COVID response. Testing COVID-19 testing response was to develop a national external quality assurance program to objectively assess the laboratory performance through testing of unknown samples from outside source. And this outside source obviously was NIH in this particular case, to obtain unbiased evidence of quality, identify systematic problems, and indicate areas that need improvement. And the importance of this program was to give assurance to the user that the kits and the instrument that are being used are functioning properly, to check and verify that the users interpret the results correctly, and verifies that there are no major errors in the process control, and quickly recognize any problems within the instruments or the users at installation. So these are actually our four cycles, or I would say phases. In phase 1, we selected 10 laboratories because it was a pilot, and we have a network of influenza-like illness and severe acute respiratory illness surveillance sites in 5 provinces, and we identified those 5 laboratories, and then there are 5 or 4 provincial public health labs. But most of the public sector laboratories were targeted in this pilot project. In the second phase, we extended and we included about 52 laboratories. And in phase 3, another 50 set of laboratories, mostly private sector laboratories, were covered. And in phase 4, we have around 42 laboratories, again mostly from the private sectors, were selected. And this is our the whole was developed by NIH team, and we at NIH we were able to through intense contribution by our scientists and hard work, we were able to prepare panels, and we these panels were prepared and tested and evaluated within the institute before we pack them up and shipped to the subnational laboratories or the private sector laboratories, where they were analyzed and they shared back the results, which were evaluated, and we generate external quality assurance performance report and give the feedback to the laboratories. Basically, our aim was to have non-infectious proficiency testing material with conforming with the allowable or detectable viral loads, and we added stabilizing reagents to maintain the RNA integrity, especially at the room temperature, and we normally ship a panel of 5 PT samples at ambient temperature, along with the reporting sheet and testing instructions. We give around 9 days once they receive the samples to share the results. And passing score in all our quality assurance program is 80%. This is I'm not going to detail, but actually we tested our panels at 3 temperatures: at the room temperatures, at the refrigeration temperature, that is 2 to 8 degrees, and at incubation at 36 degrees centigrade for 1 week, and we observed for any variation in cycle threshold limits. And these are the geographical distribution. I think we as I already shared, mostly the laboratories which were targeted was in the major cities, and in fact the labs, most of the labs are actually operational within the large cities, in Karachi, Lahore, Islamabad, Quetta, Peshawar, and this is the province-wise distribution. So in the first cycle, when we in the first cycle, that was sort of a pilot. We have the results from the 10 laboratories. Only 1 lab was scored 100%. 3 laboratories was 80 to 90%, and 4 laboratories were less than 80%. While two of the labs, they were not, they didn't respond in time. This is our second cycle, and again, we have segregated here into public sector labs and private sector labs. We actually in this cycle.
Dr. Noor Fatma, please mute your mic. Dr. Noor Fatma, please mute your mic.
In number of labs from public sector in the second cycle was 43, and among these 43, 24 scored 100%, while 8 had a score of 80 to 90%, and the number of labs which scored less than 80 was 7, and there were 4 labs which were non-respondent. And in private sector during our second cycle, 8 labs were included from the private sector, and all scored more than 100%. This is the third cycle, and in this we have 7 public sector labs. 3 of them scored 100%, 2 of them 80 to 90%, and 2 of the labs, they were less than 80%. And as far as private sector, because in this cycle we targeted private sector laboratories, and there were 38 labs, and 22 labs got 100% score, and 80 to 90, around 15 labs were able to get 80 to 90% score, and one of the lab was less than 80%. And this is the result. These are the results of the cycle 4, and we have 34 private sector labs and 8 public sector labs, and among these 22 of the labs they scored 100%, and 15 were 80 to 90%, and one of the lab was less than 90. And these are and among the 8 public sector labs, 7 scored 100% and 1 was 80 to 90%. With this particular experience with external quality assurance program, there are certain issues, and we came up with certain recommendations as well as we move forward with different cycles. There was, although the users or the kit manufacturers have provided cutoff limits for cycle thresholds, I think there was the lack of understanding among different laboratories how to optimize that reporting. Due to I think cost implications, a lot of kits have been tried. That's why there was no uniformity. So we at NIH, we used a threshold limit of 35 CT value to declare a case as a positive or a negative. But there are certain labs which are using 30 CT value of 32 as a positive or negative. I think this understanding and reporting of CT value was missing. But again, because of lack of standardization, I think it was not a good idea to have CT values reflected within the reports. There is a lack of understanding among the operators or interpreters of PCR to differentiate between two positives and negative signals. And multiplex kits again was multiplex kit means targeting more than one targets for PCR, and the interpretation was quite complex in such circumstances. We recommended that there is a need for on-site training, and we did a lot of on-site trainings, especially during the first and second cycle. Once there was issues with certain laboratories, and technical assistance to the laboratories which were scoring less than 80%, and both remotely and at on-site trainings were given. These laboratories were given all the SOPs and all the standardized algorithms to improve their laboratory performance. In conclusion, our external quality assurance program remained successful. I think Pakistan was one of the few countries within the AMRO region which have successfully conducted this quality assurance panel, and it was again done in with all the remaining commitments of the institute. We have to our scientists were not only performing these assays, and I'll share our experience as well later in the last couple of slides. Our samples remained, the proficiency testing samples or panels remained well stabilized. There were no sample deteriorations, and they worked on multiple kits with range of viral gene targets. Subsequent to our experience with the external quality assurance program, we developed guidelines on lab decontamination, which were also prepared and shared with all the laboratories, and then training and on-site troubleshooting was addressed. So that in fact is a success, and we would like to build on our external quality assurance program experience on COVID-19. And this is a very unique experience in an emergency, in a pandemic situation where a lab is committed, that we came up, we developed this program, and we launched this program. This is one of very important achievement of the institute as a national reference or a national public health laboratory, that we were able to launch this program. We are right now conducting another program on AMR, external quality assurance for AMR, antimicrobial resistance as well, and we are in process of getting that ISO certified. So that is one of the mandate of the institute, and we delivered this. And these are the overall challenges which COVID PCR, as far as COVID PCR is concerned. I think it's more during the early phase of pandemic, new and rapidly evolving technologies, but still the process is going on, and every week or every month we have new technologies, new evolving technologies which are introduced, and a lot of companies approach us. There is high expectation of accuracy from PCR-based assay, and especially during the 2020, I think there was lack of quality control materials, and there is still emphasis is not given to quantitative testing, and as I mentioned earlier, multiplex or new genetic test targets are introduced and are rolled out as part of PCR assays. And our laboratories are still struggling to develop appropriate quality management system for PCR-based tests. Mostly labs are have adopted an ad hoc quality management system. I think very important is to have a systematically derived or systematically built quality management system within the laboratories is very important, so that our laboratories remain capable to conduct PCR-based tests or other laboratory tests. Staff competencies, training was identified as a continuous process, and availability of staff, because people don't consider that the lab workers can also get COVID. So especially during the Delta and Omicron, a lot of our staff got COVID, and they were out of lab for 10 days or 14 days, and nobody realized that that fatigue staff, and in a protected phase of epidemic, but still we are working, we delivered, and we had actually and I would like to share my personal experience at NIH, and it obviously this is not me, I think it's NIH team experience. We have to manage a huge workload, touching around 5,000 samples per day without any automation. We have actually operating throughout the pandemic with semi-automation, and the only other lab in Pakistan is the Punjab AIDS Control Lab, which has processed around 7,000 to 8,000 samples per day during the peaks of epidemic, but they have automation with them. So we have actually, and at the same time we have to carry out additional testing for rapid antigen test validation. We have to do sequencing for variants of concern. We have to develop guidelines, national guidelines. We have to impart continuous trainings and capacity buildings. We were asked by National Disaster Management Authority. We have been asked by DRAP to test the kits and look at their standardization and reagents. We have to make sure that such huge workload is how to manage this huge workload through sustainable supplies of kits. And as far as patient load is concerned, I think there are a lot of self-prescription. Several countries, they adopted rapid antigen test for self-testing, but here in Pakistan, this was not, adapted. Home testing using rapid antigen test. So the load remained on PCR-based testing in all the provinces, I would say. Our clinician, they were not, identifying the cases or recommending or prescribing based on case definition. I think this is very important in outbreaks and pandemics and even epidemics. Um, uh, Rather than self-prescription, I think there is a way to do testing and tracing. And but here in Pakistan, there have been, we have observed that people start, contact tracing based on their own understanding, and there is definitely a method for contact tracing. There is a conventional methods, and that has to be followed. It has not to be decided by the families themselves. So we have been facing examples of having large families of 20 individuals coming just for testing without understanding the concept of contact tracing. I think one of the very important part was traveling requirements, which were, PCR-based testing was linked to traveling requirement. It is still being, used by many countries, although the Western and Western countries, they have, I think, they are in process of slashing this requirement out. And then there's a lot of commercial interest. And very important part was the role of regulators during the earlier phase of pandemic. I think there is definitely need to, there is definitely more role by the regulatory authorities, healthcare commissions, and health regulatory authorities to inspect those laboratories and to make sure that they are compliant to the checklist, which can be reviewed as well once we came out of the pandemic. I think this is my last slide, and I thank you all for your listening, and I'll be happy to take any questions.
Thank you so much, Dr. Salman. Now I will request Major General Amir Ikram. Can you, sir, add something, sir? Major General Amir Ikram, sir. Yes, sir. Sir, yes, sir. Yeah, we are hearing you, sir.
I'm Professor Mulazim. Can I,
जी, मैडम सलाम अलैकुम. मेजर जनरल आमिर इकराम साहब हैं?
जी, आमिर इकराम साहब I'm sure होंगे, क्योंकि उन्हीं के इंस्टीट्यूट पर रिप्रेजेंट हो रहा है. ये नजर नहीं आ रहा.
Okay, madam, can you add something? Okay, madam Ifat, can you add something?
I am just going to ask a couple of things from Madam Salman. Salman, thank you very much for praising us for the wonderful work that NIH has undertaken over time. इसमें कोई शक नहीं है कि that was a much needed step जो आप लोगों ने टाइम दिया. इसमें जो मुझे थोड़ी सी क्वेरी है कि जो आप लोगों ने सैंपल्स भेजे लैब्स को, were they prepared and they were traceable to some international standard, WHO standard or some other recognized standard? Number one. और सेकेंडली ये है कि इसको क्वालिटेटिवली आपने असेस किया, इसीलिए आपने फिगर और परसेंटेजेस में किया. वर देयर एनी अटेम्प्ट कि आप सीटी जो थ्रेशोल्ड्स हैं उसकी बेसिस के ऊपर हम स्टैंडर्ड डेविएशन इंडेक्स कैलकुलेट कर लेते, और सिमिलरली क्या वो रिफ्लेक्शन कर देता कि ये जो है इनपुट्स की जो है सेंसिटिविटी क्या है, और क्या आपने अपने सैंपल्स पे ये जो क्यूसी का सैंपल था ईक्यूए का, क्या अपने रिकॉर्ड में आपके था कि क्वांटिटेटिवली क्या था, सो दैट द लैब्स कुड हैव बीन गाइडेड कि ये जो है उनकी सेंसिटिविटी का इशू है. थर्डली ये है कि क्या आप एनआईएच के अंदर प्रमोट कर रहे हैं कि अगर फॉर एग्जांपल इफ आई वांट टू सेंड माय स्टाफ फॉर ट्रेनिंग, उनको एंडोर्स कर दें वहां पे कि दे आर ऑप्टिमल इन देयर परफॉर्मेंस. तो ये मेरे तीन थोड़े से इसमें क्वेरीज थी. कैन यू जस्ट थ्रो लाइट ऑन दैट?
जी, ब्रिगेडियर आमिर.
I'm here, Professor Mulazim.
जी sir. Ji sir, can you, because this is also your favorite topic,
Yes,
can you add something, sir?
I think my remarks in the previous talk, in one of the talks generated this session. Thank you very much, Salman. Very enlightening and highly informative talk. and I really enjoyed every word you had said. And I'm witness to it, what NIH has done. I think COVID-19 is alhamdulillah, a success story for Pakistan. We can very confidently say that Pakistan is one of the three top countries who have handled it very well and without damaging much of its economy. And I think NIH has a leading role in this success story. The NIH probably the most important player in this success. And I'm witness to that, how they first developed the PCR in Pakistan. They went to China and brought those kits. And I'm also witness to the training sessions conducted by NIH and Dr. Salman, especially General Amir. They are heroes of this all
Yes,
jihad against,
really, they are heroes. Yes.
crusade
both.
against COVID. And this ICAS was very well needed, and I sent initially a document to General Amir suggesting this ICAS, and but they had already started working on it. You very rightly said, Salman, that health regulators have to be very serious about monitoring these labs. And, incidentally, I'm one of the inspectors of the Punjab Health Commission. Punjab being the largest province, they have done it very well, and they are very strict on giving permission to the PCR and COVID-19, and now they are doing monitorings. And in their performa, they have just mentioned the quality control measures. Not specifically, they have mentioned the NIH, but I've personally added the NIH CAS program in that performa. And I'm now stressing or emphasizing all the labs which I visit that they must participate in NIH program, and they should produce the results of. So that will be very important when the labs will produce the results sent from NIH to the inspectors. Only then they will be allowed to carry on the service. Thank you very much.
Yes, Brigadier Amir, I am also very thankful to you. And you know, Brigadier Nuzat, Professor Nuzat, from the last 3 months, we continued a series of lecture about the lab. I will request Professor Rafiq Khanani from Karachi. Can you, sir, add, because this is also related to you, Professor of Microbiology, Professor Munir is also with me sitting this and hearing all of you. Professor Khanani, can you add something?
Yep. Assalamu alaikum. I think that the talk of Dr. Muhammad Salman has been very excellent, and NIH role is highly commendable. I agree with Brigadier Saab as well as you that NIH has played very important role and very timely role to standardize and to provide us the opportunity to get the external quality assurance done.
Yes. Yes.
However, in Dr. Salman's talk, they mentioned about provincial public health laboratories. I'm not very sure that how these laboratories are performing, because we are not in touch with them. So I will definitely request the provincial public health laboratory should also be strengthened if we have to take the control measures appropriately and in timely manner.
जी डॉक्टर सलमान, एक क्वेश्चन है आपसे, व्हाट इज प्रोफिशिएंसी टेस्टिंग सिस्टम? डॉक्टर सलमान
जी मैं अब आपके बारी बारी सब क्वेश्चंस के आंसर देता हूँ। पहला क्वेश्चन था जी सीटी की क्वांटिफिकेशन। So I think a very important part which is which was highlighted is the quantification. We obviously probably I forgot the name of the डॉक्टर साहब जिन्होंने ये पूछा था क्वेश्चन। बहुत important pertinent question है। डॉक्टर अल्ताफ ने पूछा था। अच्छा, इसमें
प्रोफेसर नुज़रत है, डॉक्टर सलमान
मैडम नुज़रत थी मेरे ख्याल।
जी अच्छा, इसमें जो बेसिकली द प्रॉब्लम वाज टू कल्चर द वायरस, टू गेट अ गुड यील्ड ऑफ वायरस, वो हमने अवॉइड किया थ्रू आउट आवर क्वालिटी प्रिपरेशन पैनल जो है। इसमें हमारे पास जो हमारे पास बेस्ट बिट थी वो हमारे पास ये था कि जब पीक्स ऑफ आउटब्रेक थी हमारे पास, तो वी हैव सर्टेन सैंपल्स जिनकी सीटी वैल्यूज काफी लो थी, यानी दे हैव वेरी हाई वायरल लोड्स। तो हमने उनको थोड़ा क्वांटिफाई करके और उनको एडजस्ट करके उनसे हमने पैनल्स प्रिपेयर किए थे। वी अवॉइडेड कल्चरिंग द वायरसेस। उसकी एक तो ऑब्वियसली बायोसेफ्टी लेवल 3+ की रिक्वायरमेंट है। वी वुड नॉट एंडेंजरिंग आवर स्टाफ एज वेल, बिकॉज लैक ऑफ कुछ इस पे जाहिर है कल्चर के ऊपर, एक नए वायरस के ऊपर सडनली वी वुड नेवर लाइक आवर स्टाफ टू बी एक्सपोज्ड ऑन हाई वायरल लोड्स डूइंग कल्चर। तो हमने इसको अवॉइड किया था। Definitely we standardized and adjusted all those positive samples with high viral load, और हमने उनकी सीटी वैल्यूज की रेंजेस एडजस्ट की थी, और उनके पर्टिकुलर फिर पैनल्स जो हैं वो डिफरेंट 4 या 5 के पैनल्स बनाए थे डिफरेंट सीटी वैल्यूज के। उसके अलावा अभी तक इसकी क्वांटिफिकेशन जाहिर है द टाइप ऑफ डिजीज और द टाइप ऑफ चैलेंज व्हिच वी आर फेसिंग इज कि अगर हम सक्सेसफुली qualitative results dish out कर रहे हैं, I think that itself is an achievement, whether it's NIH or a provincial public health lab or a private sector lab। तो अभी तक हम लोग इसमें quantification quantitative इसकी रिपोर्टिंग अभी तक इसकी recommended नहीं है as far as SARS-CoV-2। And definitely we would like to train the staff, जो भी आप भेजना चाहते हैं हमने पहले भी किए हैं, और मजीद standardization on quality control and as well as other aspects of biosafety, biosecurity, quality management system। तो जो भी ट्रेनिंग कोई करवाना चाहते हैं तो we are open and we will facilitate any kind of training। There is a comment from Dr. Sir Amir Ijaz, and I would like to thank sir for your kind words for NIH, means a lot to us। And sir, इसमें जो and it's very heartening to know कि आपने एक्सटर्नल क्वालिटी एश्योरेंस स्कीम को उधर इंट्रोड्यूस करवाया है पंजाब हेल्थ केयर कमीशन में। आई थिंक अदर प्रोविंसेस शुड आल्सो आप लोग अपने प्लेटफॉर्म को यूज करके जो रिस्पेक्टिव हेल्थ केयर कमीशन हैं उनको इस पे एनकरेज करेंगे, इसके एक्सटर्नल क्वालिटी एश्योरेंस प्रोग्राम में शामिल हो। आई थिंक we learned from this, it was a learning experience, it is not easy to launch such a program। मैंने जैसे कि अपनी टॉक में कहा कि हम AMR के ऊपर भी एक कर रहे हैं शुरू, और हमने वो आज से 5 साल पहले शुरू किया था, लेकिन जो अभी हमने उसमें उसको हमने जो रिसेंटली अभी उसमें मॉडिफिकेशन की हैं, तो जो लैब्स वो जिनके पास हमारे पैनल्स आएंगे दे विल रियलाइज कि हमारी अभी रिपोर्ट कितनी कॉम्प्रिहेंसिव होगी। तो लाइकवाइज हम इस प्रोग्राम को और इम्प्रूव करना चाहते हैं। इसकी एक सर्टेन ISO सर्टिफिकेशन होती है, एंड इसमें थोड़ी सी हमें फॉरेन टेक्निकल असिस्टेंस चाहिए होगी, मे बी फ्रॉम WHO या कोई लंदन स्कूल ऑफ हाइजीन। आई हैव रिक्वेस्टेड एक्चुअली लंदन स्कूल के हमें थोड़ा सा हेल्प करें इसमें। तो सर आपका बहुत शुक्रिया। बाकी सूबों से रिक्वेस्ट करते हैं कि वो भी अपने हेल्थ केयर कमीशन को उनका रोल जो है और उसमें पार्टिसिपेशन को एनकरेज करें।
डॉक्टर सलमान, वो क्वेश्चन रह गया प्रोफिशिएंसी टेस्टिंग
किनका?
ये था ना कि डू यू हैव NIH हैज एनी प्रोफिशिएंसी टेस्टिंग सिस्टम?
जी, हम लोगों ने अल्हम्दुलिल्लाह हमारा तो ग्लोबल पार्टिसिपेशन थी, और ये हमने बहुत अर्ली कर लिया था। लाइक इन अर्ली फेज ऑफ पेंडेमिक हमने सबसे पहले अपने सैंपल शिप किए थे डेनमार्क और हांगकांग, वहां से हमारे क्लियर हुए थे, हमारे 100% रिजल्ट्स आए थे। और अभी भी हम लोग इनके जो SARS-CoV-2 के पैनल्स हैं इनमें, और हमारे जो इन्फ्लुएंजा के पैनल्स हैं हमारे, माशाल्लाह अल्हम्दुलिल्लाह मोर देन 90% स्कोर्स हैं। NIH की जो अपनी हमारी जो पार्टिसिपेशन है इन ग्लोबल लैब। आई थिंक दिस इज द क्वेश्चन।
जी सर, एक आपसे रिक्वेस्ट है कि प्रोफेसर मुलाजिम हुसैन बुखारी, कैन आई रिक्वेस्ट यू टू अरेंज another lecture from Dr. Salman or Dr. Brigadier Ijaz on which type of accreditation is required for diagnostic lab and why should it be CAP, JCI, PNAC? ये डॉक्टर अल्ताफ साहब ने कहा है, तो why not sir, we can request it। तो इसके अलावा if anybody, डॉक्टर
अच्छा
कदूस,
सर आई एम डॉक्टर असगर जावेद
जी
from Multan.
जी सर, आज तक क्वेश्चन। जी
अच्छा सर,
प्रोफेसर असगर जावेद।
एक तो सर ये पूछना था कि ये जो कोविड एंटीजन टेस्टिंग एयरपोर्ट्स पर शुरू है और स्टिल इन इंस्टीट्यूशंस हम पीसीआर किट्स ऐसे लॉन्ग प्रोसीजर्स पर हैं, तो क्या ये इंस्टीट्यूशनल परमिशन मिल सकती है कि रैपिड एंटीजन टेस्ट जो है वो इंस्टीट्यूशन में भी शुरू कर दिया जाए?
मेरे ख्याल में असगर जावेद ये शुरू हो चुका है, ये पता नहीं कि इजाजत NIH की है या नहीं है। जी डॉक्टर सलमान, कैन यू ऐड समथिंग अबाउट इट? रेड
जी बिल्कुल, मैं बता सकता हूँ इस पे। इसमें जो NCOC ने ये जो एक तो ये ट्रैवल जो इनबाउंड पैसेंजर की खत्म कर दी है रैट टेस्टिंग, ये तो खत्म हो गई है। दूसरा ये कि इंस्टीट्यूशनल, चूंकि हमने अपनी दिसंबर 2020 में एंटीजन की गाइडलाइंस इशू कर दी थी, नेशनल गाइडलाइंस, और उसमें हमने इनकरेज किया था प्रोविंसेस को कि आप लोग इसको रोल आउट करें। पंजाब समहाउ रिमेन्ड रिलक्टेंट टू अलाउ, इनफैक्ट नॉट पंजाब या गवर्नमेंट ऑफ पंजाब या पंजाब हेल्थ डिपार्टमेंट में थोड़ा सा कोई इशू था। आई डोंट नो व्हाट वाज द रीजन बिहाइंड, but they have not allowed rapid antigen in their contact tracing or testing. So I think असगर साहब, आपका जो इशू है मेनली आप पंजाब हेल्थ डिपार्टमेंट से पूछ लें, नेशनल लेवल पे ये अलाउड है एंड यू कैन यूज देम, और इसकी गाइडलाइंस भी अवेलेबल हैं।
इसमें मैं ऐड कर दूं कुछ
सर?
पॉइंट ऑफ व्यू फ्रॉम पंजाब।
जी डॉक्टर आमिर इजाज़त।
I'm a bit advocate of not including rapid testing from the labs. And Punjab Health Commission has not allowed especially the rapid antibody testing, and because the labs start malpracticing and they give false negatives in their reports, but they have certainly allowed carrying out the antibody and antigen testing, which are laboratory based, LDTs, laboratory derived tests, which include ELISA and CLIA, and preferably CLIA, the chemiluminescence methods. And I think it was a good policy. It was not a bad policy, because in rapid testing, there are many false negatives. So this is purely my own point of view. Thank you.
Okay, sir. जी ब्रिगेडियर नुज़रत जी।
Regarding rapid antigen test, what happened is recently I had to review the policies because one of the hospital lab asked me that they were stopped.
ब्रिगेडियर नुज़रत, आपकी आवाज सही नहीं आ रही।
Let me come here to the computer. मैं जो recently encounter किया on an inspection by Punjab
Health Care। अब ठीक है।
पंजाब हेल्थ केयर कमीशन इंस्पेक्शन के लिए उस हॉस्पिटल में आए और उनकी हॉस्पिटल लेबोरेटरी को उन्होंने मना किया कि रैपिड एंटीजन टेस्टिंग ना करें। सो आई हैड टू गो थ्रू द गाइडलाइंस जो पंजाब गवर्नमेंट की हैं एज वेल एज नेशनल। डॉक्टर सलमान बिल्कुल ठीक कह रहे हैं, नेशनल लेवल के ऊपर जो पॉलिसी है वो क्लियर है, लेकिन उसमें उन्होंने एक चीज जिसके ऊपर रैपिड एंटीजन टेस्ट का रोल जो है वो काफी सिग्निफिकेंट है और इम्पोर्टेंट है, वो है प्री ऑपरेटिव स्क्रीनिंग, स्पेशली इन इमरजेंसी सिचुएशन में जहाँ पे आपको इमरजेंसी सर्जरी करनी पड़ती है। उस सूरत में कोई अगर पॉलिसी है कि जी आपने उसको प्री ऑपरेटिव स्क्रीन करना है, तो उस वक्त PCR का शायद वो टाइम टर्न अराउंड टाइम की वजह से और अर्जेंसी की वजह से रैपिड एंटीजन टेस्ट वुड बी मोर प्रेफरेबल। तो एक ये वाली कंडीशन है। पंजाब ने लास्ट जो उनकी गाइडलाइन आई है वो रैपिड एंटीबॉडी टेस्ट के ऊपर है, उसके बाद एंटीजन टेस्ट को उन्होंने कहीं टच नहीं किया, ना हेल्थ केयर कमीशन ने ना उनके किसी और अथॉरिटी में। सो दे आर टोटली साइलेंट ऑन रैड के ऊपर, जबकि नेशनल पॉलिसी है। तो आई थिंक इसके ऊपर मैं भी कंफ्यूज थी कि अगर उनकी कुछ ना कुछ, वेदर दे अलाउ इट और नॉट अलाउ इट, एटलीस्ट दैट शुड बी अवेलेबल ऑन द गाइडलाइंस जो कि ओपन सोर्स हैं, ताकि हमारे जैसे लोग उससे फायदा उठा सकें। तो इसमें डॉक्टर आमिर, मेरे ख्याल में आई वुड रिक्वेस्ट यू कि आप सेंसिटाइज कीजिए उन्हें, क्योंकि रैड इज वेरी कॉमन और उसको फिर यूज या अब्यूज दोनों कैटेगरी में डाला जा सकता है अगर एक्सप्लिसिट गाइडलाइन नहीं होगी। तो उसको
ये तो सही है। I will definitely do that, but if you allow me, I will ask probably the last question from Salman, because Salman
एक क्वेश्चन है सलमान सर, एक क्वेश्चन और है, एक डॉक्टर कदूस का है और एक प्रोफेसर मुनीर साहब जी आप।
अस्सलाम वालेकुम, मैं प्रोफेसर मुनीर हूँ, रिटायर्ड प्रोफेसर ऑफ माइक्रोबायोलॉजी, किंग एडवर्ड मेडिकल यूनिवर्सिटी। अभी रैपिड टेस्ट की बात हो रही थी। आई एम श्योर जो भी गाइडलाइंस पंजाब हेल्थ कमीशन ने दी है वो उन कंपनियों की जो क्लेम्स है जी, इसकी स्पेसिफिसिटी इतनी है, सेंसिटिविटी इतनी है। मेरा क्वेश्चन डॉक्टर सलमान से है कि क्या आपने कोई इंडिपेंडेंट स्टडी NIH में कोई कंपैरिजन किया है इन रैपिड टेस्टिंग, एंटीजन टेस्टिंग और एंटीबॉडी टेस्टिंग जो एलाइजा पे है? ब्रिगेडियर साहब फरमा रहे थे इसका कंपैरिजन विद द यू सी द गोल्ड स्टैंडर्ड टेस्ट दैट इज द PCR। कोई इंडिपेंडेंट आपने काम किया है या ये सारी रिकमेंडेशंस जो है वो कंपनियों के क्लेम्स के ऊपर है? थैंक यू वेरी मच।
जी वेरी इंपॉर्टेंट क्वेश्चन डॉक्टर सलमान।
जी सर, ये हमने एक नहीं, हमने कम से कम एटलीस्ट आई थिंक वी हैव कंपेयर्ड 6 और 7 जो कंपनी है उनकी एंटीजन टेस्ट। थोड़ा सा क्लियर कर लें, पहले हम एंटीजन की बात कर लें। रैपिड एंटीजन टेस्ट जो है ना, इट इज वेरी यूजफुल। ऑनेस्टली स्पीकिंग, आई हैव पर्सनली यूज्ड फॉर मतलब आई मीन होम टेस्टिंग। और अच्छी जो कंपनीज हैं इनकी, जो स्पेशली रॉश हैं, एपेट हैं, एसडी बायोसेंसर इनिशियली आ रही थी, कुछ चाइनीज कंपनीज बहुत अच्छी हैं जिनकी CE मार्किंग है। मैं आई एम नॉट एडवोकेटिंग एनी ऑफ द कंपनी, जस्ट मेंशनिंग कि हमने इन कंपनी 4, 5, 6 कंपनियों की हमने की हैं। और इनमें इतनी एडवांसमेंट आई है कि अब ये सिर्फ एंटीरियर नेरीज से सैंपल लेके दे आर रिकमेंडिंग, और थ्रोट से भी करने के लिए रिकमेंड कर रहे हैं। जो हमारी फाइंडिंग्स हैं वो ये है कि तकरीबन जो 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 परफॉर्मेंस है कुछ किट्स की, इट्स जस्ट आई वुड से 5% लेस देन PCR है इनकी सेंसिटिविटी। अगर कोई इफ PCR जो है 100 में से 80 केसेस पिक कर रहा है, तो ये जो किटें हैं तकरीबन अराउंड 70-75 केसेस पिक कर लेती हैं, डिपेंडिंग अगेन ऑन the type of sample that is collected and the timing of the sample is very important. और हमने ये evaluate किए हैं, रियल टाइम में evaluate किए हैं, और हमारे पास कईयों के रिजल्ट्स भी अवेलेबल है जो वो हम किसी प्लेटफॉर्म पे दे भी सकते हैं उसमें। तो
मैं यहाँ पे
जी सर, ये रैट
सा
एंटीजन
कमेंट है
सर,
सॉरी आपको इंटरप्ट कर रहा हूँ। ये जब आप कह रहे हो कि इसकी सेंसिटिविटी 80% है, आई एम श्योर इसकी स्पेसिफिसिटी जो कंपनियों के क्लेम है वो तो बहुत ज्यादा है, लेकिन आपने चूंकि इंडिपेंडेंट कर लिया, मुझे बहुत खुशी है कि आपने 4-5 स्टडीज की है। तो मेरे ख्याल में मास टेस्टिंग में हमें ये टेस्ट जो है चूंकि ये कम कीमत में है, तो वी शुड कम अप विद यू सी some sort of recommendation which suits to our country rather than follow the international guidelines.
सर एक्चुअली इंटरनेशनल गाइडलाइंस भी यही कहती हैं, मास टेस्टिंग जो ये यूरोप, अमेरिका, इंडिया, चाइना, ये सारी रैपिड पे हुई है। जो 8-8, 10-10 लाख टेस्ट करते रहे ना दिन में, ये इनमें से जो 80% टेस्ट रैपिड एंटीजन पे हुए हुए हैं जो, और ये बहुत लार्ज स्केल पे रोल आउट हुए हैं वेस्टर्न कंट्रीज में। पाकिस्तान में मैंने जैसे कहा बहुत अंडर यूटिलाइज है, स्वाय KPK के और थोड़े से लेवल पे इस्लामाबाद में। मेरा नहीं ख्याल कि ये पाकिस्तान में वाइड स्प्रेड यूज हुई है, और दिस इज द रीजन कि हमारी टेस्टिंग थोड़ी सी लो रही है। ये आपकी बात बिल्कुल ठीक है। और इसको इसीलिए इसको हमने शुरू में जब ये एसडी बायोसेंसर की आई थी, हमने शुरू में इसको एवेलुएट किया था। इट वाज नॉट दैट बैड अ किट, और स्पेशली इन सर्कमस्टेंसेस में जब आप कॉन्टैक्ट ट्रेसिंग करने जाते हैं ना, तो बजाय इसके कि आप एक फैमिली के 10 मेंबर हैं और उन 10 मेंबर्स को आप PCR लें और उनका आए और वो तब तक उनको बंद करें, तो वो देयर एंड देन आप 15-20 मिनट्स पे डिसाइड करते हैं जी ये बंदा आइसोलेशन में जाएंगे, ये क्वारंटीन में जाएंगे। आइसोलेशन वाले बंदे पॉजिटिव होंगे, जाहिर है उनको आप 14 दिन के लिए बंद करेंगे, क्वारंटीन वालों को 7 दिन के लिए। जो रिक्वायरमेंट्स जैसे जैसे हुई, अब तो खैर ये सारी चीजें आहिस्ता आहिस्ता खत्म हो रही हैं। मतलब आइसोलेशन का पीरियड अब 5 डेज पे कर दिया विद ओमिक्रॉन। तो ये बड़ी इंपॉर्टेंट किट हैं, और आई थिंक ये अंडर यूटिलाइज रही है हमारी कंट्री में, और आप लोगों की तरफ से इनकरेज करना चाहिए ये कम्युनिटीज को। और इवन पब्लिक सेक्टर में मैंने तो बल्कि हमने NCOC लेवल पे भी कहा था कि प्राइवेट सेक्टर्स को और फार्मेसीज को ऑथराइज करेंगे ये डिस्पेंस करें और होम टेस्टिंग हो। लेकिन हमारे यहाँ सिर्फ इसमें ये प्रॉब्लम है, दैट इज है हाउ टू कैप्चर दैट डाटा। वो हमारे लोग इतने पढ़े लिखे
That
नहीं
is
हैं.
very difficult. That is very
Exactly.
difficult how to collect the data and compare it. Yes,
Yeah.
Dr. Salman, I give you one of the example of my own experience. My daughter was showing the sign and symptom of COVID, and I performed the rat test and it was negative. But I sent the sample to the lab, and after 12 hour the 24 hour the test was positive. तो मेरा तो ये है कि there is some disparity, but as the Professor Munir, he is the Baba of Professor Microbiology, and he recommended, and we also. And last question, Dr. Kadus has raised the hand. Dr. Kadus, what you want to ask? Dr. Kadus, you can ask yourself. Dr. Kadus, you have raised the hand. You can ask the question. If there is no question, I would.
मुझे एक बस लास्ट
जी सर.
नहीं, अगर प्रोफेसर मुलाजिम साहब की इजाजत के साथ I'll just give one comment. सलमान, आपसे मेरी पुरानी सलाम दुआ था, आप जानते हैं, आपका बहुत ही अच्छा था, और दूसरी मुबारक आपको देना चाहता हूँ कि आप 5000 PCR रोजाना करते रहे विदाउट ऑटोमेशन. हैट्स ऑफ टू यू. थैंक यू वेरी मच.
इसी के साथ ही आज का लेक्चर, आज की प्रेजेंटेशन मैं आई वेरी थैंकफुल Dr. Salman to you, and also very thankful to Major General Amir Ikram. No doubt he is busy and could not able to present the comments. And Dr. Amir, Brigadier Amir Ijaz and Dr. Nuzat, we will also request you to arrange another lecture in continuation of this, as the Dr. Altaf has requested the accreditation of this lab. Inshallah, hopefully we will meet very soon in our this continuation of our lab quality assurance, lab quality control, and basic importance of the lab testing and assurance of the clinicians with our lab. Thank you so much. Thank you so much. Thank you so much, everyone.